Good evening, everyone. Welcome to our webinar, which will focus on pediatric exocrine pancreatic insufficiency, diagnosis, and management. Next, please. I'm Dr. Veronique Morinville, Associate Professor of Pediatrics at the Montreal Children's Hospital, McGill University. I will be co-chairing the program this evening and will serve as your moderator. I will be joined by my co-chair and speaker, Dr. Maysam Abu-Alhaja, who is the Medical Director of the Pancreas Care Center at Cincinnati Children's Hospital Medical Center in Cincinnati, Dr. J. Antonio Quiros, who's an Associate Professor at the Medical University of South Carolina in Charleston, Dr. Mark Lowe, who's Chief of Pediatric Gastroenterology, Hepatology, and Nutrition at the Children's Hospital of Pittsburgh of UPMC in Pittsburgh, and Tammy Miller, who's a Clinical Dietitian Specialist in the Cystic Fibrosis Program, Children's Hospital of Wisconsin in Milwaukee. We also wish to acknowledge Dr. Terry Sigman, who is an Associate Professor of Pediatrics, also at the Montreal Children's Hospital, who served as our CME content reviewer on behalf of NASPGHAN. Next, please. We would like to thank especially NASPGHAN and the NASPGHAN Foundation for sponsoring this webinar, and to AbbVie for providing support for this program. Next, please. Before we start, a few quick instructions. You will note that there are a number of interactive areas beneath the main webinar window. You will need to scroll down to see them. Firstly, there is a chat area where you can comment or ask questions. Please submit your questions at any time. There is no need to wait until the end of the webinar. At the conclusion of the presentation, we will answer as many questions as time allows. Below the chat area are 3 participant polls that will occur during the presentation. Please do not respond to them until we present the poll questions during the program. At the bottom of the page, there is also a link that allows you to download the full set of slides in PDF format. And finally, also at the bottom of the page is an important link to receive CME and CEU credits. Next, please. So let's begin by discussing the objectives and rationale for doing this webinar. Next, please. Firstly, I think it would be important to start off with the starting point, which would be what is the definition of exocrine pancreatic insufficiency. We will refer to exocrine pancreatic insufficiency as EPI in this webinar. EPI can be described as a condition that is characterized by the reduction or deficiency of exocrine pancreatic enzyme activity and bicarbonate in the lumen of the intestines to below what is required to digest food normally, which leads to maldigestion and malabsorption. And children will typically present with symptoms that result from this. Next, please. Why are we doing this presentation? Well, EPI is poorly understood by many and probably most pediatricians, even pediatric GI specialists. EPI does not equal cystic fibrosis for all cases, even though it is the most frequent etiology responsible. The relative rarity of EPI has created multiple gaps in people recognizing the possible presentations, ordering the proper diagnostic workup, initiating proper management, and following up these children. And of course, the consequences can be significant. Lack of recognizing EPI can lead to severe growth, nutritional, and other consequences for a child. Next, please. So what we hope to cover in this presentation will be as follows. 1, to illustrate symptoms, presentations, differential diagnoses, and testing of children with possible EPI. And we will do this through 2 case scenarios. 2, we'd like to review the digestion of carbohydrates, proteins, and fats to understand the rationale for EPI therapy. 3, we'd like to describe some pancreatic enzyme replacement therapy, PERT, and other treatments and how they are monitored. And 4, we'd like to go through some real-life troubleshooting with using of PERT in particular special patient populations. Next, please. And now we will move on to our case presentations that will deal with workup and diagnosis. Next, please. The first case will be presented by Dr. Maysam Abu-Alhaja. Maysam, next, please.
Okay, thank you, Veronique. So I will be presenting the first case this evening, and the case that I will present will start by an outline. So we'll go over the case itself and then the workup that we have undergone for this patient, so the imaging, the labs, and the stool tests, and then talk about the differential diagnosis of EPI and finishing up my part with the endoscopic pancreatic function testing. Next, please. So our case is an 8-year-old female who presented to the clinic with a chief complaint of diarrhea over the last few months prior to seeing us. And the diarrhea was described by the family and the child by being oily, yellowish and orange in appearance, and sometimes foul smelling, and would float on the toilet. There was a history of vague intermittent belly pain, but really no prior episodes of documented acute pancreatitis. Next, please. So when we pulled her growth chart, the most striking thing on exam was really her weight loss. And she had lost 11 pounds of her total body weight, so made up 17% over 5 months duration, as you see in the CDC growth curve. Next, please. So moving on more further in the history, she didn't have any history of vomiting, fatigue, or joint pains, or rashes, or mouth sores. She really didn't have any recent travel history. She had a healthy past medical history and really a negative family history. Next slide. So on our differential at that point was mainly infectious etiologies leading to diarrhea, inflammatory causes for diarrhea like inflammatory bowel disease or celiac disease, along other intestinal diseases, systemic illness, and as well as pancreatic. And under pancreatic at that point specifically, we thought about cystic fibrosis, Schwachman-Diamond, or chronic pancreatitis. Next slide. So the workup initially included just a general lab work. We started with a complete blood count, complete metabolic panel. We did some thyroid testing, TSH and T4. We also checked her amylase and lipase, and they were all within normal limits. And her tissue transglutaminase IgA antibodies was also normal, and she had a normal IgA levels. So that kind of was our screening test for celiac. Other testing that we did at that time included stool studies. So we had C. diff, Shiga toxin, H. pylori antigen, stool cultures, rotavirus, ova parasite, but all of them were negative. Next slide. More workup that was more specialized at that point was among the other etiologies that covered the differential that I presented earlier. So we did a fecal elastase, and that was low. It was 15 mics per gram, with the normal being above 200 mics per gram. We didn't do a 72-hour fecal fat collection in this case. We also did a sweat chloride, and it was normal. We did a fecal calprotectin to screen for inflammatory disorders such as IBD, and it was normal. And we also did some nutritional labs, including fat-soluble vitamin levels, which were within normal limits, besides the vitamin D 25-hydroxy level, which was 17, and that was low. Next slide. So here I'm going to present a poll question, and this is going to be the first of 3 interactive participant polls. So the poll questions are below the main webinar window, so you must scroll down to see it and submit your response. We'll report the results in a few minutes after each question. So I will go ahead and start by asking the question. So we are at this point suspecting a pancreatic origin as a cause for this steatorrhea. What would you do next as a next best step to confirm a pancreatic origin as a cause for this steatorrhea? Repeat a fecal elastase, B, check fecal chymotrypsin, C, doing an endoscopic pancreatic function testing, D, doing an ERCP, and last, would you perform a dry-link pancreatic function test? So please go ahead and submit your polls, and we will give the answers in a bit. Next slide, please. So along the lines of more pancreatic workup, trying to find out what happened to this child, we did also serum total immunoglobulins. So her IgG was elevated at 1,400 milligrams per deciliter, and I show the ranges here between brackets. We also had an elevation specifically in IgG4 levels, and it was 320, while the normal for her age range was to be reported less than 189. We also did a test called immunoreactive trypsinogen, and it was really low, less than 1.2 nanograms per ml, and the normal range is reported between 10 and 57. We also did genetic testing. So the Schwachman-Diamond gene sequence analysis was negative. We sent a pancreatic, one of the commercially available pancreatic gene tests that tests for cystic fibrosis transmembrane regulator gene and PRSS1, which is the cationic trypsinogen gene, as well as PINK1 and the chymotrypsin C gene, which is CTRC. And it came back positive for only one thing. This patient was found to be heterozygous for a pathogenic mutation in the CFTR gene called PR1070Q. So she was just a carrier for one copy. Next slide. We did imaging studies to look at this child's belly, but specifically at the pancreas. So we chose at that point a magnetic resonant imaging cholangiopancreatography, so an MRCP. This imaging showed a small volume pancreas with residual low-grade inflammation throughout, with emphasis mostly on the body and tail. The pancreatic duct was collapsed and was not seen, which is a good thing. So she didn't have pancreatic ductal dilation, which sometimes is something you see in chronic pancreatitis. And then there was no peripancreatic inflammatory abnormalities seen at that time. Findings were really consistent with a history of chronic pancreatitis, potentially with a residual low-grade inflammation. And I will show the image in the next slide. So as we see here, we have MRCP, axial T1 images of the pancreas. In both of them, it shows diffusely decreased parenchymal signaling, as you see and pointed by the arrows. They are really best appreciated in the tail of the pancreas on image B. But overall, the pancreatic volume is decreased, so if the patient had a condition called the pancreatic atrophy, which is something we see with chronic pancreatitis and tissue loss over time. The pancreatic duct was collapsed and not seen. Next slide.
So thank you to everyone who responded to the poll question, which was, what is the next best step that will confirm a pancreatic origin as a cause of the steatorrhea? 28% of you thought A, repeated fecal elastase. 19% of you thought B, check the fecal chymotrypsin. 53% of you wanted to perform an endoscopic pancreatic function testing. None of you wanted to perform an ERCP, and none of you wanted to perform a Drailing pancreatic function testing. So now let's go back to the case presentation by MySam to see how this came about. Next, please.
Great. So we had a good turnout for answers, and that really stimulates a good discussion, and that really shows that we don't have a perfect test for every patient. So what we did for this patient next was an endoscopic pancreatic function testing, mainly because it is a test that would show that the steatorrhea is directly stemming from the pancreas rather than other intestinal causes. But I would like to start by covering, as you see in this slide, fecal fat collections and the different tests for fecal fat collections, because this is a very good starting point as well for working up pancreatic insufficiency. So for fecal fat tests, we have the qualitative test, which is a Sudan stain, and this one is not diagnostic for fat malabsorption because it really varies based on what the patient ate at any day. So it's a one point in time qualitative testing. How about the quantitative testing? And the quantitative test is the classic one that we know. It's the 72-hour fat collection. You really have to do an accurate recording of how much does the patient take in by mouth of fat and record how much they excreted over 72 hours. We mark the start of the collection by a red dye, or in other institutions by a corn, for instance, and then you mark the end of the 72-hour collection. And then a definition of it is that in an adult, it is more than 7 grams fat per stool per day, and the patient has to be on a 100-gram fat diet per day. Steatorrhea in general is reported to be in kids if the fecal fat is more than 7% of dietary intake if the patient is older than 6 months, but it's more than 15% of dietary intake in patients that are less than 6 months of age. And this is what we call the coefficient of fat absorption. Next slide, please. Fecal elastase, a very commonly used test because it's available, it's non-invasive. It has continued to be a commonly used test in clinical practice. So I think in that case, we did repeat the fecal elastase on another occasion. So I agree with the people who responded to that. But again, this is one of the tests that they have their own limitations. When you have mild forms of EPI, the sensitivity and specificity is low. It also could be falsely positive in delusional states, i.e. diarrhea, which our patient had. It does have low specificity when you have other intestinal disorders, but it's really the best if it's severely low, so in the advanced pancreatic disease. Next slide. Fecal elastase, the definitions of EPI based on this test are: if the value is less than 100, then it's severe pancreatic insufficiency. If the value is between 100 and 200, then it's indeterminate, and usually we would repeat the test. If the value is above 200, then we say this is a normal pancreatic function. Again, it could be normal in the early stages of EPI, so just keep that in mind in the workup. Another important aspect of fecal elastase is that it fluctuates the first year of life. So the initial values could be different from values at the 1 year of age when the patient is done kind of growing, because it does really fluctuate from month to month in the first year. Next slide. Comparison of fecal elastase to fecal chymotrypsin, and not every institution has the fecal chymotrypsin available, but it's important to know the differences. So fecal elastase is superior. It has a higher sensitivity according to some studies, but also the elastase does not react with porcine enzymes, which are the pancreatic enzymes that we give for supplementation. So you could perform that if one is on the enzyme, but you can't really perform the fecal chymotrypsin. If a patient is taking pancreatic enzymes, you actually have to stop them for a little period and then do the test. Next slide. Immunoreactive trypsinogen, and it is one of the oldest tests around, and it does have value when you are looking for non-invasive testing to work up pancreatic insufficiency like we did for this patient. So the basis of this test is that stems from newborn screening for cystic fibrosis. So as we know, it is almost in every state in the United States where we do it as a screening test. So immunoreactive trypsinogen levels are high in a newborn. If they are, then that's a positive screening test for cystic fibrosis. So the child gets screened by genetic testing and sweat chloride and so on. Two basic principles. Immunoreactive trypsinogen in the pancreatic inflammation would be high in the serum. If you have a pancreatic insufficiency, would be low in the serum. Next slide, please. Let's talk about endoscopic pancreatic function testing as a closing remark for my slides. And this test is really one of the really gold standard to diagnose chronic pancreatitis in adults. In children, we do have variable methods and variable sensitivities and specificity, so there is not a single agreed upon test to do ePFT in children. But I will walk you through the test that we did for this specific patient, and it's a method that's been described before. But basically, direct endoscopic pancreatic function testing is really a test when you stimulate the pancreas with either CCK, cholecystokinin, or secretin, and then collect fluids directly that are secreted from the pancreas. Next one. So in this patient, as you see, I'm showing the first image, which is pre-stimulation. Then the next image would be after we stimulated and you could see the fluid pouring out in the second portion of the duodenum against the ampulla of water. And then the third image is really when we introduce the ERCP catheter to collect that pancreatic fluid directly from the second portion of the duodenum. Next slide, please. So herein is the protocol that we used in our institution, and it has been reported before in pediatrics, where we give the IV human secretin at 0.2 mics per kilo or cholecystokinin at 0.04 mics per kilo, and really the studies have shown that both are comparable in results. We give it at 0 time point, and then we wait 5 minutes to collect our first sample of the pancreatic fluid in the way that I showed you. We collect all the fluids with a ERCP tapered catheter just to avoid dilution with acidic components that could be in the scope as it's passing through the stomach. And then we put the we put the fluid in tubes, Eppendorf tubes, and we immediately place them on ice, and then they get shipped to this lab at Women and Children's Hospital, and then we measure enzyme activities for trypsin, amylase, lipase, and chymotrypsin. Next slide, please. So here is a real test from our patient that I presented where the 5 and 10 and 15 minutes collections had adequate pHs, so you would believe that the test is adequate because we want the pH to be basic to believe it. And then if you look at trypsin, amylase, lipase, and chymotrypsin, in the different collections, it was below the cutoff, which is what they call at the very end of the table the abnormal reference range. So this patient was not making enough of these enzymes at the 3 different time points. So this patient was called pancreatic insufficient and was started on pancreatic enzyme replacement therapy for treatment. Next slide, please. And here is just something for academic purposes that I show. It's still an unpublished data, but we're working on gathering more, where we made curves based on real patients who are pancreatic insufficient, as you see in the red lines, and then patients who are pancreatic sufficient, who, as you see in the blue lines. So really there's a big range, as you see with the error bars, but that's the maturation process, because these are patients from neonate period up to 20 years of age. But you can really see that you could separate pancreatic sufficient from pancreatic insufficient in the different enzymes. Next slide, please. So our patient had chronic pancreatitis due to autoimmune pancreatitis, and as per the INSPIRE criteria, she did meet at least one of the following. It was really that she had abdominal pain consistent with this. She really had indolent kind of abdominal pain in the pancreatic area along the years, but was never diagnosed with chronic pancreatitis, and she also had imaging suggestive of chronic pancreatitis. She also had point number 2. She had evidence of exocrine insufficiency and imaging suggestive of chronic pancreatitis. And then also, as per the INSPIRE criteria, if you have endocrine insufficiency and have image findings of chronic pancreatitis, you would be chronic pancreatitis. So if a patient meets any one of these, then they are, and our patient met 2 of those criteria. Next slide, please. So autoimmune pancreatitis type 1, not to deviate from the main subject, just to cover it here, is that she got the diagnosis because her IgG4 was more than 2 times the upper limit of normal. She also had image findings that are suggestive of AIP, and she had resolution of pain, and her IgG4 normalized after a steroid course, but unfortunately she remained EPI, and she continues to be monitored for that with therapy. So here I would like to present our next speaker, Dr. Antonio Quiros, who will walk us through the second case.
Thank you, Maisa. Again, please reminding everybody to submit your questions through the presentations so that we can get to them at the end of the talk. This time we're going to talk about differential diagnosis, specifically focusing on genetic causes of exocrine pancreatic insufficiency. We'll do it in the case, starting with the case. Also, remember that with genetic testing, it's important to have counseling available for patients who are evaluated and found to have specific mutations. And genetic testing in patients who have undergone blood transfusions need to be delayed, at least 2 weeks for packed red blood cell transfusions and 4 weeks for whole blood transfusions. And in cases of patients who have undergone bone marrow transplantation, fibroblast cultures are needed for genetic testing. Next slide, please. In this case, a 12-year-old female who was sent to us for evaluation for chronic exocrine pancreatic insufficiency. Her symptoms were chronic diarrhea, abdominal pain, and poor weight gain. She had a history of infections and documented Steatorrhea and low fecal elastase, which is in the indeterminate range, was done. MRI was reported to be normal at an outside facility, and her issues resolved with pancreatic enzyme replacement. Her growth and weight gain stabilized, and she was sent to us for the evaluation. Next slide, please. Her genetic testing. included testing for cystic fibrosis, PINK1, which is serine protease inhibitor Mucosal type 1, which is a facilitator gene suspected to be associated in a significant proportion of patients with recurrent pancreatitis, and PRSS1, or carcinogen gene, which is associated with hereditary familial pancreatitis, and we'll talk about that in a bit. Patients also had testing for Schwab-Montbodi syndrome, which was reported to be negative. Next slide, please. Here's an image of the MRI that came to us with this patient. Pancreatic parenchyma itself looked homogeneous. The pancreas itself was small. There was no ductal anomalies noted. And anatomy of the liver and bile ducts were normal. Of interest, when you looked at pre-contrast and post-contrast phase in the study, pancreatic contrast pickup was very delayed, suggestive of decreased cell mass within the pancreas. Next slide, please. An endoscopy was performed, which showed a normal duodenum. Histology was also normal. Endoscopic ultrasound evaluation was also done. Pancreatic parenchyma itself was relatively homogeneous with no significant hyperechoic stranding, acinerization, or ductal changes suggestive of chronic pancreatitis. A fine needle aspiration biopsy was performed as well, in which no acinar tissue was obtained, but connective tissue was recovered. So at this point in time, we had no diagnosis for this patient, but Schwab-Montbodi syndrome was suspected based on clinical history. So we proceeded with a bone marrow biopsy, which showed a slightly hypocellular bone marrow. And even though this can be affected by sampling, we felt that it was suspect, and we were lucky. Next slide, please. That the patient was going to undergo cystic resection in the pelvis laparoscopically, so we piggybacked our surgeons to do a pancreatic biopsy. And this patient, we showed battery replacement of pancreatic tissue, and thus confirmed our initial suspicion that this patient has Schwab-Montbodi. So the question is, okay, so why Schwab-Montbodi, and what other options do we have for diagnosis? Next slide, please. So the differential for congenital pancreatic insufficiency is relatively narrow, and most of these disorders are relatively rare. Cystic fibrosis is the most common cause of exocrine pancreatic insufficiency. Schwab-Montbodi, Johanson-Blizzard Syndrome, Pearson Marrow-Pancreas syndrome, and then isolated enzyme deficiencies were relatively rare. Of note, congenital enterokinase deficiency can be sometimes difficult to nail down. Its enterokinase activity is dependent on duodeноmucosal integrity. Also, enterokinase, also known as enteropeptidase. So pancreatic enzyme activation is in the lumen, duodenal lumen is mediated by this enzyme. And if you have duodenal injury, you will have low enterokinase activity. Congenital lipase deficiency also is relatively rare. Lipase deficiency is associated with mutation in chromosome 10, and in these cases, fecal elastase will be fine as only the lipase activity is impaired. Next slide, please. Cystic fibrosis, the most common cause of exocrine pancreatic insufficiency in children. About 90% of all cystic fibrosis patients will have EPI. The incidence is 1 in 2,500 a live person in the U.S., and carrier state is about 1 in 30 in Caucasians. Carrier state will be significantly affected by ethnicity. So carrier state can be about 1 in 46 for Hispanics, 1 in 65 for individuals of African extraction, and Asians tend to have a very low carrier rate to 1 in 90. Exocrine pancreatic insufficiency is not in patients with 2 severe mutations, but can occur even in patients who have 1 severe and 1 mild mutation. There's over 2,000 gene mutations that have been associated with cystic fibrosis, and that's important when you think of the number of panel of mutations that can be found in the genetic testing panels. Next slide, please. Regarding testing, sweat chloride remains the gold standard. It's important to know that it needs to be done in a reliable and experienced lab. Genetic testing, some of the panels that are available from commercial laboratories can be very limited, as they will depend. The results can depend based on ethnicity, and not all disease-causing mutations are picked up. Genetic sequencing will provide entire sequencing of the entire CFTR gene, but interpretation can be sometimes difficult. Next slide, please. Shawman-Diamond syndrome is an autosomal recessive disorder with a prevalence of 1 in 77,000 births. Is the second most common cause of EPI after cystic fibrosis. It's characterized by bone marrow dysfunction, skeletal anomalies, and EPI. The pancreatic function can improve over time, and through the life of these patients, the main risk they have is for myelodysplastic syndromes and leukemia, which rate of leukemia can be 15 to 20%. And these patients need yearly evaluations by hematology team to monitor them for this. Genetic testing can have reported to be up to 90% sensitive, but broad experience suggests that current available commercial gene test actually has close to 70% sensitivity, and significant clinical suspicion is required. The function of this gene is unclear. It's felt to affect ribosomal function and mitotic spindle stability, and the involvement of different cell lines in different locations is variable, so it can be very heterogeneous, and the phenotype not well defined. Next slide, please. Johanson-Blizzard is an autosomal recessive disorder, and usually these patients have very characteristic facies due to hypoplasia of the alveoli, so they have small beaky noses. Once you've seen one, you never forget. It's one a mentor once told me a long time ago. They also have problems with the inner ear and EPI due to pancreatic insufficiency, and basically they have replacement of pancreas by connective tissue. The mutation associated with this disorder is in the ubiquitin ligase, or UBR1 gene. So these patients actually have congenital pancreatitis. They have gland degradation in utero due to active pancreatic injury. Ductal structures are preserved, so they actually produce water and bicarbonate normally, but acinar tissue is missing, with connective tissue replacing the space where the acinar tissue should be. More importantly, these patients have no hematologic anomalies noted. Next slide, please. Pearson bone marrow-Pancreas syndrome is a multisystemic mitochondrial cytopathy with bone marrow abnormalities, variable kidney, liver involvement, and exocrine pancreatic insufficiency. This patient can have severe macrocytic anemia from early infancy, and they have pancreatic fibrosis and acinar atrophy. They will have characteristic bone marrow failure, and the bone marrow findings are very important to note. They have vascularization of hematopoietic precursors, and this disorder actually consists of several mitochondrial mutations with variable tissue expression. For those who survive infancy, they can have severe lactic acidosis episodes associated with viral infections, and if they do survive into early childhood, they have Kearns-Sayre syndrome, which is oculomotor disease with ragged red fibers. Next slide, please. Obviously, we cannot not talk about celiac disease, which can be sometimes tricky to differentiate from EPI. Clinical presentation can be very similar, especially in early severe cases. Most of those children who have, 20% of children who present with celiac can have elevation of serum amylase and lipase, which can make things confusing. And also exocrine pancreatic function will be affected to some extent because of duodenal mucosal injury and low enterokinase and secretin activity. Also, in case with severe mucosal injury, the resolution of EPI and pancreatic enzyme function normalization can be delayed, so it can take many months on a gluten-free diet for things to normalize. Moving on, to pass it on to Dr. Mark Lowe to talk about the management of exocrine pancreatic insufficiency. Again, remember to submit your questions. Thank you.
All right, thank you, Antonio. So my task is to talk a little bit about the management of EPI. And to understand that, I think we need to understand a little bit about the physiology of digestion. Next slide. So I think everyone's familiar with the major nutrients that are in our diet. They include the macronutrients, carbohydrate, protein, and fat, and the micronutrients, which are vitamins, electrolytes, and minerals. And fluid, obviously, is an important part of our diet as well. And before we proceed, we're going to go along with our poll question, which is shown on the next slide. And the symptoms of pancreatic exocrine insufficiency are mainly caused by maldigestion and malabsorption of which nutrient? A, carbohydrate, B, protein, C, fat, D, zinc, E, both A and C. So please enter your answer now. And we'll come back to the results in a moment. Next slide. So let's start with the nutritionally important carbohydrates. Starches make up a large amount of our carbohydrates in the diet. They include amylose and amylopectin, which we'll describe in a moment. There are disaccharides, sucrose, and lactose. There are also monosaccharides in our diet. The most predominant are glucose, galactose, and fructose. There's also dietary fiber, which in humans is largely indigestible. The disaccharides and monosaccharides do not require pancreatic function for either digestion or absorption, but the starches do. Next slide. This shows the diagrams of amylopectin and amylose on the top, amylopectin on the bottom. These are polymers of glucose. They contain mostly alpha-1,4 linkages, but there also can be branches with alpha-1,6. Amylase is only able to cleave the alpha-1,4 linkages and is unable to cleave the alpha-1,6 linkages. Nor is amylase able to cleave the linkages of the sugars that are involved in the alpha-1,6 linkages. So this results in the production of maltose, which is 2 glucoses, maltotriose, 3, limit dextran, which is the products after digestion of the branch points, and also glucose. These require intestinal brush border enzymes and transporters for further digestion. So starch digestion can be affected by both the abnormalities of the pancreas and abnormalities of the intestine. Next slide, please.
Okay, so thank you, Mark. So going back to the poll question, which was the symptoms of pancreatic exocrine insufficiency are mainly caused by maldigestion and malabsorption of which nutrient, you answered in the following fashion. So none of you thought that it was carbohydrates. None of you thought that it was protein. 68% of you responded that it was fat. None of you thought that it was zinc, and 39% of you responded that it was carbohydrate and fat. So with that in mind, let's go back to the presentation by Mark to see who was correct. Next, please.
So starch maldigestion can result in symptoms. It can cause osmotic diarrhea, and it also may act by causing changes in the microbiome composition or in metabolites made by the microbiome. Remember, the bacteria normally can metabolize dietary carbohydrates that reach the colon. Next slide, please. Protein digestion is accomplished by a series of proteases that are released by the pancreas. All of these proteases are secreted as inactive proenzymes, and intestinal enterokinase is important in activating these enzymes, particularly protrypsinogen to trypsin, which then is responsible for activating the other proenzymes. These enzymes have specific cleavage sites. They typically act on peptides that are created by gastric pepsin during digestion of proteins in the stomach. The proteins are broken down into small peptides and amino acids, and these are absorbed by intestinal brush border transporters. So just like carbohydrate, we require both pancreatic enzymes and intestinal brush border proteins or enzymes for proper protein digestion. It's also important to have digestion in the stomach, which does not occur with carbohydrates. In the next slide, we show the results of protein maldigestion, which can result in edema and ascites, which are two of the characteristics of a classic presentation of cystic fibrosis, which was more common before the days of neonatal screening. It can lead to loss of muscle mass. It can contribute to poor growth, anorexia, and skin rash. Typically, these are not commonly seen in patients with exocrine pancreatic insufficiency. In the next slide, we'll begin our discussion of fat digestion. Now, there are multiple sources of intestinal lipids. There are lipids that come from dietary fats, the bulk of these are triglycerides. The amounts shown in this slide are what are ingested by an adult in the United States, but the proportions are similar for infants and children. Biliary lipids do come from the diet, but most of them actually come from bile that is secreted by the liver. There are lipids that also come from desquamated intestinal cells and from dead bacteria. Of all of these lipids, which only about 4 grams of fatty acids will occur in the stool in a normal adult. And it's really rare to collect glycerides or partial digestion products in the stool of a normal human. So the digestion of fat is really quite efficient. On the next slide, we show the schematic of digestions of triglycerides and phospholipids, which are triglycerides, of course, make up more than 95% of the dietary fats. These are digested by lipases, which cause the release of fatty acids and monoacyl glycerol. The fatty acids can be absorbed by the intestinal enterocytes. Monoacyl glycerols are also absorbed by enterocytes, but in practice, this reaction probably goes to completion in the duodenum, and it's predominantly fatty acids that are absorbed. Phospholipids are cleaved by phospholipase A2, which is a pancreatic enzyme. It releases one of the 2 acyl chains in the phospholipid to create a fatty acid and a lysophospholipids. Both of these can be absorbed by intestinal enterocytes. Next slide, please. The digestive lipases include gastric lipase, which is in the stomach. One still reads that humans contain lingual lipase, but there's abundant evidence that this is not the case. Animals that do have lingual lipase don't have gastric lipase, and mammals that have gastric lipase don't have lingual lipase. Humans fall in the latter category. The pancreas makes a number of lipases. These include pancreatic triglyceride lipase colipase complex, which is the lipase most of us are familiar with, and the lipase that is measured in the serum with the lipase assay that's commonly done. They also make carboxyl ester lipase, which goes by some other names, including bile salt stimulated lipase and cholesterol ester lipase. This is a lipase that's also present in human breast milk and is important for digestion of dietary fats in breastfed infants. Pancreatic lipase-related protein 2 and phospholipase A2 are also important for digestion of dietary lipids in humans. In the next slide, we show the clinical consequences of exocrine pancreatic insufficiency, resulting in fat maldigestion, causes changes in the stools. They can be bulkier. Sometimes you'll see oils separating from them, but this is not a reliable clinical criteria for making a diagnosis of steatorrhea. Because fats have the highest caloric density, they're quite important for maintaining weight gain, and oftentimes patients with EPI have weight loss and poor growth. They can increase flatulence, can be a symptom of bloating. Fat maldigestion can cause abdominal pain, and importantly, it can lead to fat-soluble vitamin deficiencies. And these changes are usually predominate in patients who have exocrine pancreatic insufficiency, so fat maldigestion is really the major nutrient misdigestion that causes symptoms and problems in patients with exocrine pancreatic insufficiency. The treatment of EPI depends on pancreatic enzyme replacement therapy, or PERT. The current products and in the past are extracts of animal pancreas. In the 19th century, these were sold as digestive aids. They were marketed in the beginning of the 20th century by a company that was a precursor to the company that makes one of the commercially available enzyme replacement therapies. In 2006, the FDA decided that regulation was required for pancreatic enzymes. In part, this was because of the practice of overfilling the enzymes. So companies would fill the enzymes with more lipases and proteases than were suggested by the label, and this was so that they were still active during storage. This is no longer the case, so that if the enzymes that we get now contain the amount that they are advertised to contain. All enzymes now contain an enteric-coated capsule which dissolves in the stomach. These capsules contain beads or spheres that will not dissolve in the stomach and will dissolve when the pH increases in the duodenum and will release the enzymes. This occurs about pH 5.5 and above, so adequate alkalization of the gastric contents is important for the function of the pancreatic enzymes. Fat-soluble vitamin supplements are important in the treatment, and dietary changes may well be important. Currently, limitation of dietary fat is not recommended. There's good data that the coefficient of fat absorption does not change related to the amount of dietary fat, and so increasing so many patients are put on higher fat diets for that reason, particularly in CF. Dosing of pancreatic enzyme replacement therapy in pediatrics is really based on data obtained in patients with cystic fibrosis, and this table provides the lipase units that are provided at different ages. There are upper limits given at each of the years. These work out to about 2,500 lipase units per kilogram per meal in patients that are 4 years, between infants and adolescents and adults. In adolescents and adults, the range is from 25 to 75,000 lipase units per meal. And the dose needs to be adjusted depending on clinical symptoms. Next slide. The complications of pancreatic enzyme replacement therapy are few. Patients can have allergic reactions. The enzymes are all derivatives of porcine products, so if you're allergic to pig proteins, you may have a reaction. Oral mucositis, or inflammation of the oral cavity, was seen with enzymes that were not coated, the old preparations of Viacase. These are no longer available and shouldn't be a problem unless the enzymes are dissolved in bicarbonate and given orally. And fibrosing colonopathy, which was described in patients with cystic fibrosis and seemed to correlate with high doses of lipase, although it's unclear that the lipase or other pancreatic enzymes were the culprit. There are other possibilities. This has pretty much disappeared with decreasing lipase doses in patients with cystic fibrosis. It is important to remember that patients who have EPI from other causes are not predisposed to developing fibrosing colonopathy. So one can increase the doses, and some patients, particularly those who have had a total pancreatectomy, may require higher doses than are the standards given in the previous table and advocated by the cystic fibrosis community. Next slide, please. As with any therapy, there's monitoring that's involved. Clinical symptoms, such as abdominal pain, changes in stool, are not particularly reliable. They can be highly variable and inconsistent, and poor predictors of inadequate pancreatic enzyme replacement therapy. Anthropometrics are important, particularly body weight, BMI, and arm circumference have all been used. Patients who are on adequate therapy should have normal rates of weight gain. Muscle function has been advocated. Some places, particularly CF centers, will use hand grip strength as a monitor of muscle function. And also several biochemical tests are useful, including a CBC with differential, measurements of fat-soluble vitamins, vitamin B12, calcium, magnesium, iron, as well as trace minerals, particularly zinc, which is actually, the pancreas is very important in the metabolism of zinc, and selenium, and plasma proteins. Typically, these are done every 6 to 12 months in patients on pancreatic enzyme replacement therapy, or perhaps more often in patients who seem to be symptomatic. In the next slide, it shows an algorithm for what to do in somebody who has persistent symptoms such as abdominal pain, increased stooling. And the first step is always to assess compliance as best one can. If there are issues with compliance, then one needs to address those with more education and then follow up closely. If the compliance seems to be adequate, then taking a good history for other causes of diarrhea, which we'll mention in a moment, is important. And if there's any indication there may be another reason for an increase in stools, for instance, then that should be excluded before increasing the PERT dose. If there's no clear indication that there might be other causes, many practitioners will go ahead and increase the dose of pancreatic enzyme replacement therapy and see if that resolves the symptoms. If it does not, and the patient is not on acid suppression, it is a common practice to add a proton pump inhibitor to see if one can increase the efficacy of PERT. I think it is important to note that available evidence suggests that this is not a very efficacious approach, but it still remains in common practice. And if there are still symptoms, then additional diagnostic testing for other diagnoses is indicated. The other diagnoses one would consider would be liver disease, since decreased secretion of bile acids can lead to fat malabsorption and increased symptoms. Enteric infections, bacterial overgrowth actually is probably more common in patients who have EPI. Lactose intolerance can occur in these patients as well. Crohn's disease, which can be associated with type 2 autoimmune pancreatitis, and that can present before the intestinal manifestations. Obviously, functional disorders can occur in this patient population as well as in other patients. Eating disorders can occur, and short bowel syndrome should be considered, but would be unusual unless there's a history suggesting predisposition. And in summary, on the next slide, so all micronutrients are maldigested in EPI, but the symptoms of fat maldigestion predominate. The treatment is pancreatic enzyme replacement therapy, vitamin supplementation, a good diet. With treatment failure, one should evaluate compliance, adjust the PERT dose, consider adding acid suppression, and consider evaluating for other diagnoses. Thank you for allowing me to present to you today. And now, on the next slide, we'll move on to the presentation by Tammy Miller, who is the clinical dietitian specialist in the cystic fibrosis program at the Children's Hospital of Wisconsin, Milwaukee. Tammy, it's your turn. Thank you.
Thank you very much. In this section of the program, I'd like to share some tips and strategies to help you optimize your skills in managing enzyme administration. Before we move on to the next slide, though, which is a polling question, I would like you, once you finish the polling question, to also please submit additional questions that we can answer at the end of the program. So the polling question is to optimize enzyme therapy. This can be accomplished by all of the following except A, repeating the dose of enzymes if a feeding for an infant surpasses 30 to 45 minutes, B, giving enzymes 3 times a day, C, avoiding a grazing eating pattern, and D, frequently adjusting the dose of enzymes during times of rapid growth. We'll come back to that as we move on to the next slide. I'd like to talk just briefly about initiating pancreatic enzymes in newborns and infants. Typically, with patients with cystic fibrosis, the diagnosis is made within the first few weeks of life, and so we are starting newborns and infants on pancreatic enzyme therapy. Acceptance is usually quite good despite this young age, and we generally recommend using applesauce consistently to develop an association with that flavor and the texture of the PERT. Parents often say to me, my child is tired of applesauce, can I try something else? I encourage them to continue to use applesauce as the child will associate that texture with the flavor. We do ask that foods that are used to administer PERT are generally acidic, and when PERT is mixed with food, it should be administered as soon as possible. Parents should administer at the beginning of the feeding as much as possible using a spoon or the bottle nipple to push beads back into the mouth, because the infant will likely thrust the beads out when they're so young. Generally, enzymes are effective for about 45 minutes. If a feeding, particularly in a newborn, is exceeding that time frame, we do recommend that the dose would be repeated if the feeding is either interrupted by sleep or delayed for whatever reason. The enzymes are only going to mix with the food for about that length of time, so it's very important that the dose is repeated. Should any stray beads be noted in the infant's mouth or on the mother's breast, these should be removed, as they could cause irritation and causing mouth sores. We also recommend to parents who are starting newborn infants on pancreatic enzymes to use a very heavy diaper barrier cream on the buttocks. Oftentimes, some babies will develop diaper rash, and this can result in very severe large open areas in the diaper area. So we take the approach of prevention is the best medicine in that case. Next slide, please. In some older patients, particularly toddlers and preschoolers, when they haven't grown up with using pancreatic enzymes with their meals, beginning enzyme therapy can be very problematic, and so just administering them mixed with applesauce can be very challenging. Other foods that parents may want to try include frosting, raspberry jam, because of the seeds can also disguise the beads that are mixed with that food, ketchup, or grape jelly. Really, any food can be used. Yogurt is another popular one, but again, consistency is often the best policy for administering enzymes. We encourage parents of this age group to use positive reinforcement, and in many cases, this is adequate to develop good enzyme therapy. However, you can know that there are many toddlers who are going to say no to enzymes, and when this happens, we encourage parents to say, if you don't take your enzymes, you're not going to have this meal. And that can work for a very short period of time. If it becomes protracted, though, enlisting the help from a psychologist can be very, very helpful. And we do tend to encourage parents and other caregivers to teach young children to learn to swallow pills by the time that they're entering preschool, and for certain by kindergarten. This can simplify the administration in a school setting and helps the child be more independent with cares. Next slide, please.
So our third and final poll question related to optimizing pancreatic enzyme therapy, and it related to how it could be accomplished by all of the following except. We got much more broad answers with this one. 30% of you answered A, by repeating a dose of enzymes in a feeding in an infant if it surpasses 30 to 45 minutes. 23% of you answered B, by giving enzymes 3 times a day. 23% of you answered C, by avoiding a grazing pattern, and 17% of you answered D, by frequently adjusting the dose of enzymes during times of rapid growth. Certainly, Tammy has already touched on a couple of these aspects, and she will continue to touch on some of the other aspects as we return to her presentation. Next, please.
In the next slide, you can see that there are a couple of strategies to dose enzymes. One can be dosed on a very specific amount of enzymes that are consumed with each meal and usually with each snack. Usually snacks are dosed at about 50% of the dose of a meal. And then there is another way, similar to carbohydrate counting for people who have diabetes. Enzymes can be dosed based on fat grams consumed. The physician can prescribe enzymes based on the amount of lipase units that should be consumed with fat grams that are consumed in a meal. Typically, 500 to 5,000, 4,500 to 4,000 units of lipase are consumed per gram of fat. Dr. Lowe also gave you guidelines for dosing for meals and snacks. In our practice, we tend to use smaller strength capsules, particularly for younger age children, because it's much easier to titrate doses as the child grows and the diet advances. So for example, if a young child is taking 20,000 units of lipase, we would prefer in our practice to use 4 capsules of 5,000 strength as opposed to 1 capsule of 20,000 strength. And this is necessary because then when the dose needs to increase to 25,000, you can simply add a 5,000 strength capsule. Otherwise, if you're using 20,000 strength capsules, it's very difficult to estimate that additional 1/4 to increase the dose slightly. I think if you're using large strength capsules, it's very easy to underdose or overdose the amount of PERT that's provided with meals and snacks or grams of fat. As Dr. Lowe mentioned, the risk of fibrosing colonopathy has limited the recommended amount of lipase units consumed per kilogram per day to approximately 10,000 units. However, it's been often shown that infants who are eating frequently and teenagers who may be consuming high-fat, frequent meals and snacks are likely to possibly exceed the 10,000 units of lipase per kilogram per day. In the short term, these higher rates of enzyme dosing are usually well tolerated and necessary for adequate growth. Next slide, please. In some circumstances, enzymes may not be necessary when consuming only small amounts of carbohydrate-containing foods, such as eating a piece of fruit or drinking a small amount of juice, candies without chocolate or nuts, marshmallows, and foods that contain less than 3 grams of fat. Based on tolerance, as Dr. Lowe mentioned, enzymes may be helpful with some carbohydrate digestion as well, but oftentimes especially in cystic fibrosis patients, we are not advocating that they take enzymes with these very low-fat or fat-free type foods. These foods also tend to be very low in nutritional quality, but there are strategies such as adding peanut butter, cream cheese, hummus, etc., to maximize the fat content and nutritional content, and therefore enzymes would be required. Next slide, please. Tube feedings and pancreatic enzyme therapy is particularly challenging for patients who require overnight tube feedings or who may be in an ICU setting on ventilators and requiring nutritional support. There are various strategies to provide enzymes with tube feedings. The standard recommended therapy is administering enzymes orally at the beginning, middle, and end of a feeding. However, that's not possible in an ICU setting, and sometimes when children are sleeping through the night, they may only get the beginning and the end of the enzyme doses. Some other strategies to address enzymes with tube feedings include crushing enzyme beads and adding them directly into the formula to create a pre-digested formula. The alternative to crushing the beads may be to use a bicarbonate solution to dissolve the beads and then mix that into formula, allowing it to sit for 20 to 30 minutes before the infusion is started. This approach, though, is not FDA approved. However, it is widely used in many CF centers across the world with excellent tolerance and good weight gain. A new development in 2015 was the approval of a new product that is a cartridge that contains lipase, and when the tube feeding formula passes through the cartridge, it comes in contact with lipase, and it can digest the fat that is in the formula and results in up to 90% absorption of the fatty acids. Lastly, if a large bore feeding tube is in place, enteric-coated enzymes can be mixed with applesauce and delivered through that tube. Next slide, please. As Dr. Lowe mentioned, the most common cause of failure on enzymes is non-adherence, and it takes a skilled practitioner to work with families, particularly teens and young adults, to problem solve and come up with strategies to optimize adherence. There may be other dietary factors that can result in temporary malabsorption, such as excessive juice consumption, particularly in toddlers, in people who have EPI, over-consuming fried foods or eating for long periods of time at buffet restaurants can cause malabsorption as well. Children who graze throughout the day are likely to have difficulty with EPI because the infrequent use of enzymes may result in malabsorption. So getting patients on a very strict, structured meal and snack schedule, eating only for 20 to 30 minutes at a time, can be very helpful. During times of rapid growth, such as infancy and teenage years, it's very common that doses can be outgrown and an increase is necessary. Comorbid conditions may also contribute to enzyme challenges, particularly in cystic fibrosis. Constipation can mimic malabsorption, and so it's important to look for the cause of those symptoms. Delayed gastric emptying can also be problematic, particularly in advanced diseases such as cystic fibrosis. And as Dr. Lowe mentioned, it may be sometimes necessary to use a proton pump inhibitor should there be high gastric acid levels. In conclusion, dosing enzymes is both really science and art. There are many scientific guidelines to provide a framework for adequate PERT doses in many situations. However, there's also many nuances that can be used to optimize malabsorption symptoms and improve nutritional status. Hopefully, the information presented today will assist you in troubleshooting some common challenges with dosing enzymes. This time, I'd like to transition back to Veronique for our summary, please.
Thank you very much, Tammy. Please note there are only a few moments left to submit your questions, so please do so. And now has summary and conclusions. Next, please. I hope this webinar has illustrated the various presentations of EPI that can be abdominal pain, poor weight gain or weight loss, larger volume foul-smelling stools, steatorrhea, diarrhea, and one must consider EPI in a child that presents with some of these symptoms. The congenital causes of EPI will include number 1, cystic fibrosis, number 2, Shwachman-Diamond syndrome, and a number of rarer entities that are much less frequently seen, such as Johanson-Blizzard and Pearson bone marrow-pancreas syndrome. Next, please. The acquired causes of EPI will be primarily related to chronic pancreatitis, but it may also occur with luminal diseases such as celiac, and this is why a detailed history and physical exam are very important in teasing out what potential etiologies there may be. The workup may include an assessment of the general nutritional status, any fat-soluble vitamin deficiency, assessing and eliminating, if necessary, luminal diseases as a possibility. But there are certainly particular tests of pancreas exocrine function that exist. The indirect tests will primarily be fecal elastase. I think will be the one that is mostly used by people, although there are others that exist. And direct testing, such as endoscopic pancreatic stimulation testing, is a very interesting, promising test, but is still not broadly available. And there must be more validated pediatric norms in order to make it more accessible and standard across the board. Next, please. The management of EPI will primarily involve pancreatic enzyme supplementation. This is what you heard from Mark. This is what you heard from Tammy. This is what we need to do for them. But they also need higher caloric intakes. We can't replicate nature quite as well with our PERT. Most of them, all of them, will require supplements of fat-soluble vitamins and other micronutrients, and the growth parameters must be followed over time to make sure that we're doing an adequate job. Troubleshooting will be necessary based on the age of the child, their growth patterns, whether there's feeding tubes, and over time. And all of this is to optimize health, growth, and quality of life. Next, please. Of course, as EPI is relatively rare, there's many important directions for future research. This will include improving screening tests for EPI, as the direct stimulation tests are invasive and cumbersome at this point. 2, standardizing and validating our direct pancreatic function testing, particularly in pediatrics, is really becoming relevant, increasingly important. And 3, it would be good to improve our pancreatic enzyme formulations and delivery to improve efficacy, to improve compliance, to improve outcomes. Next, please. So at this time, actually, we would like to address some of the questions and comments that have been submitted. I will be joined by the faculty that spoke to you during this evening, and we will aim to cover as many of the questions as time allows. Now, I have a number of the questions in front of me, and there are several that relate to similar themes, and I would like to get the input from my various faculty with respect to them. So one theme in many questions has to do with the types of screening tests that are available. So there have been questions relating to the utility of a spot fecal fat for oily diarrhea, whether a fecal elastase of 100 to 200 would be sufficient to call a pancreatic insufficiency. And once we talk about these indirect tests, then we'll move on and talk, because there were several questions that had to do with some of the direct testing. So maybe I can start off actually, because Sam, you initially dealt with the presentation that detailed some of these indirect tests. What would you say with respect to the worth, the quality, with keeping in mind that in different countries, in different hospitals, and people with different plans with respect to their health care, that they may or may not have access?
Yeah, I mean, this is a very good question, Veronique, because that's what we see in common practice. So we usually do not order the subjective tests, like a spot check for oil in the stool, just because it varies in the same person depending on what they eat. So if they eat a Big Mac burger, they're going to be positive. If there is a day that they didn't, then probably not, even if they don't have EPI. Now, moving on to fecal elastase, which is measuring the fecal elastase by ELISA testing. And Mark and Antonio, please feel to comment on that too. But it is when I get a borderline of 100 to 200, I usually would repeat. And I would repeat if it's a chronic pancreatitis case, and I know it's chronic pancreatitis because we use that test in surveillance to monitor when is a chronic pancreatitic going to develop exocrine pancreatic insufficiency. I usually wait at least a month after the attack. And even when I do repeat testing, I wait also a month between the testing. I think this is something as us in the INSPIRE consortium we talked about a few times. A simple instruction my nurse team even gives to the patients is that, you know what, since you have variations within your own stooling pattern, if a day you have a looser or liquidy stool, do not send this one to the lab and wait for the one that is a little more formed.
Thank you so much, Sam. Would anybody else have comments to add?
Well, I would only add that for patients who have, borderline intermediate low fecal elastase, always is important to rule out other causes of low pancreatic enzyme function, particularly like duodenal injury, and also to make sure that there's no if it's clinically indicated, consider doing cystic fibrosis screening.
Yes. Second question that came before I get to the direct pancreatic function testing had to do with genetic testing. So if someone is felt to be potential for Schwachman diamond or potential for CTRC, there's a question, what have been the panel's approach to how they are sending out for the genes? Are they involving their genetics department? What is the process? And maybe Sam and Antonio, you could comment on that relating to your cases.
For commercial testing for lab for Charlemagne diamonds, fibrosis, there's several commercial labs that do these. Also, obviously, some large hospitals, university hospitals, offer Cystic Children's, Cincinnati. I know Pittsburgh does a lot of these gene tests specifically for hereditary pancreatitis gene. They usually describe this gene. For Ambry Genetics, it's a panel for pancreatitis, which does the genetic screening for the cystic fibrosis, the whole gene sequencing, plus PINK1, PRSS1, and then GeneDx. Mysam, do you have anything else to add?
No, I would agree, Antonio. It's mostly, since there are different technologies, and I think the next generation sequencing has replaced all older methods. So if a lab does sequence the whole gene, I would believe that the results are going to be adequate for that patient, whether it's for CFTR testing or Schwachman diamond testing.
Great.
I would just say that there are also a couple new companies that are starting to offer genetic testing for a broader range of genes that have been associated with pancreatic disease, including the SBDS gene. And so those will be available in the very near future.
I think for me, at my institution in Canada, we actually usually involve our genetics department to help us, thinking that they will also offer genetic counseling should there be an abnormal that's not a definite result. So I think really locally seeing what's available through the hospital, as that was mentioned by the faculty, there are various that will offer a panel of testing. Now, another set of questions had to do with the direct stimulation test for pancreatic function. And I would actually like to hear from Mark Lowe as well as Sam and Antonio, because not everything is done at every center. We intended to demonstrate what can be done in the process of diagnosing someone, but not every center will do everything. Not every center will do endoscopic pancreatic function testing, and it may not be necessary in every case. So I'd actually like to start with Mark to understand what your approach is in clinical practice to a case that you think is pancreatic exocrine insufficient. They would have a low pancreatic elastase, let's say, for example, elastase. How would you proceed after?
Well, I think it depends on the clinical situation. So if you have a patient that has a low fecal elastase, poor weight gain, has abnormalities of chronic pancreatitis and imaging, I think that one can proceed clinically and assume that patient has pancreatic insufficiency. You will have a few false negatives with that approach, but overall I think you would do well. Now, the patients that are a little more challenging are the ones that don't have abnormalities in pancreatic imaging. And so I think another confirmation besides a fecal elastase of pancreatic insufficiency needs to be done before starting pancreatic enzymes. And that's going to depend on what you have available. I still think that a 72-hour fecal fat, if done correctly, it can be helpful. And most patients, although it's often said to be disliked by families, I've never had any family refuse to do it. And then I think endoscopic pancreatic function testing has become much more common. One of the panels, someone asked, why not do a Drelling tube test? I think that those have really become rare. Most institutions don't even have Drelling tubes, and most GI physicians don't know how to do that procedure. And there's good data in the adult literature that the endoscopic pancreatic function tests are as reliable as a Drelling test, as long as they're done appropriately. And there are multiple ways to do them now. But I think most important is that one collects multiple time points with endoscopic pancreatic function testing, which does prolong the procedure slightly, but not that much longer. And it's also important to handle the samples quickly. I know Meissen mentioned putting them on ice right away, but it's just as important to get them to your lab where they can be frozen quickly and send them off, because one of the most common reasons for low enzymes in that analysis is improper storage. So I typically would confirm in most patients who have a positive fecal elastase, which is often done either by me or someone else before they've seen me, with either a 72-hour fecal fat test or an endoscopic pancreatic function test.
Great. We'll get to one more question, and actually this would be for Tammy. What would be your feeling? We had a question with a patient that was struggling with more pills that they added, so they gave them prescriptions for two different strengths of pancreatic enzymes. So let's say, for example, a 12,000 and a 6,000. How do you feel about the practice of giving two types of pills to patients?
Well, I think in some situations there's a lot of things to consider. Probably the number one thing in the U.S. particularly could be copays. If you have two separate prescriptions, there easily could be two prescription copays, and that could be double the cost for the family. However, if that's not an issue, I don't see any problem with the practice. Obviously, whoever else is taking care of the child, whether that be a teacher in a school, a daycare provider, a grandmother, a neighbor, anyone who's administering the enzymes, the dosing instructions have to be very, very clear. I think it's easier for young children to learn to swallow those smaller capsules, and so when teaching the young children using the smaller capsules, such as the 5,000 or the 6,000s, is usually preferable. But if capsule burden is a problem, certainly this could be an option to consider.
Great. Thank you, Tammy.
You're welcome.
So in closing, please note that you can download the presentation slides in a PDF format. Simply scroll down to the link found beneath the webinar window. We will be posting a recorded version of the webinar on the NASPGHAN website, www.naspghan.org, in a few days. And as a reminder, you'll be able to obtain CME and CEU credits through the link posted on the registration page. As a close, as NASPGHAN Pancreas Committee Chair, I felt privileged to have the opportunity to be involved in the development of this webinar. I would like to thank my co-chair, Meissen Abu-Alhaja, and the rest of the faculty, Antonio Quiros, Mark Lowe, and Tammy Miller, for their hard work and for sharing their wisdom with us. I want to once again thank NASPGHAN and the NASPGHAN Foundation for sponsoring this program, and AbbVie for providing support for this program. Without their involvement, this webinar would not have been possible. We also extend our thanks to all participants in tonight's webinar, and in particular for the submitted questions. And with this, good night to all.